just going to talk to you about a research project that I've been doing. I'm looking for biomarkers for anthracycline cardio-toxicity. So just a background, so anthracyclines, we know that in patients that are getting anthracyclines, 1 to 5% of them will have clinical heart failure, and a much higher percentage will have asymptomatic cardiac dysfunction, up to 26%. And while we know that cardiotoxicity can occur is more common at the higher doses, it can certainly occur even at lower doses, lower cumulative doses, even if it's less than 250 milligrams per meter squared, which is really around the dose that's commonly given for breast cancer. 260 is a typical breast cancer dose. So looking at a more contemporary analysis to try to figure out what is the true incidence. This is a large series in Italy of over 2,700 patients that are undergoing anthracycline-based chemotherapy, and it excluded patients with high-dose Herceptin. So looking at these patients, they had an average cumulative dose of over 300 milligrams per meter squared of anthracycline, so pretty higher risk, or pretty average risk, I would say. Under 400 is what is that magic number we're always taught in medical school, which it certainly does increase your risk, but it's a continuum and not a over or under binary risk of cardiotoxicity. In this cohort, 9% of patients developed cardiotoxicity, and that was up to almost 10% of the patients treated with breast cancer, and slightly less than the patients that were treated with non-Hodgkin's lymphoma. And we often define anthracycline cardiomyopathy as early, late, and acute early, late. And this is what's interesting about this study is since we often see the manifestations of the anthracycline cardiotoxicity late, we assume that most patients develop the cardiotoxicity late. But in this study, which is really a contemporary series and a prospective study, 98% of these patients developed cardiotoxicity within the first year, defined by a drop in EF below normal and more than 10%. And looking at the risk factors for what we already know about anthracycline cardiomyopathy, the risk factors, certainly the cumulative dose is a risk factor, the length of the length of time, which is questionable with the recent data that I presented. Age at diagnosis, so extreme of ages, certainly over 65, under 4 years has been associated with an increased risk. Female gender has been associated with an increased risk, but that might be some bias because most of these, a large amount of these patients are breast cancer patients. And high individual anthracycline doses, so there's some evidence, particularly in pediatric patients, that a continuous infusion might have more cardioprotection versus boluses. And then the type of anthracyclines, liposomal derivatives are associated with decreased risk of cardiotoxicity, but not zero certainly. And concomitant radiation therapy and concomitant other cardiotoxic therapy, including Herceptin and other Herceptin antagonists, can increase your risk. In addition, we think pre-existing cardiac risk factors also increase your risk of cardiotoxicity. Not very well established with good literature, but common sense and some literature does suggest that having hypertension or other cardiac pre-existing diseases does increase your risk. So how do we, just want to give background before I go into the study of what the current state of the art is in terms of screening and detection and how we're diagnosing patients with cardiomyopathy that are receiving anthracyclines. So what's recommended by all the societies in ASCO, American Heart Failure Society of America, is that we should serially assess the left ventricular ejection fraction. Of course, none of these will recommend specific intervals of doing so. Or which modality to use, although there is now a consensus statement that does suggest the utility of echo over MUGA, but traditionally there has not been an endorsement of that until recently. Echo obviously doesn't have radiation compared to MUGA. It's cheaper. It gives us more information, including hemodynamics, valvular information, diastolic information, and of course newer techniques that have been used for research in this field, including 3D volumetrics as well as strain. We do know the limitations of echo. There is a 5 to 10% inter-observer variability. And then also having a drop in EF is typically a late finding. And so you certainly want to have something that would predict the drop in EF if you could. And strain is certainly one of those things that can do so. Global longitudinal strain does typically occur before the onset of systolic dysfunction in these patients. And if you look at just the review of the literature, it has a very good negative predictive value and a modest positive predictive value. So it seems to be more specific than sensitive, but it certainly is useful to screen these patients. And so clinically, all patients that we're seeing that are getting chemotherapy that is potentially cardiotoxic are getting strain echoes, or we're at least trying to get strain echoes. It can be a challenge to get it routinely. I think we're batting probably 70%, if I had to guess, in terms of how often we're getting it on the appropriate patients. And screening is really important because early treatment matters. And this is a study from Italy that shows that patients that were treated with ACE inhibitors in this particular study that developed cardiomyopathy, if you were to diagnose them within 6 months and start treatment within 6 months, there's a higher likelihood of responding and normalizing your ejection fraction. Whereas if they were delayed 6 months since the time of anthracycline exposure in terms of starting heart failure medications, the incidence of response was almost zero. Now that's not necessarily true in the real world. We certainly have patients that have a low EF that are more than 6 months out that have responded. So it's not, I don't think it's really 0%, but this graph is effective in showing that really early treatment is crucial for these patients. So what are the mechanisms of anthracycline cardiotoxicity? This has there's been lots of different theories over the last few decades. The most commonly touted theory up until recently at least was the oxidative stress free radical formation theory. Certainly iron binds with doxorubicin and leads to oxidative stress. Also, there's mitochondrial damage, evidence for the role of mitochondrial damage. And then most recently, Dr. Ye, who was at MD Anderson until recently, showed that the way anthracyclines work is it's a topoisomerase inhibitor, and he found that there are topoisomerase 2 beta receptors in the heart, and these can be irreversibly damaged. So, but that doesn't necessarily exclude the oxidative stress and other pathways of pathology. And so just looking at what we have now, this is what from the European Society of Cardiology position paper, how should we detect cardiotoxicity? Certainly echo is advantageous, including potentially 3D echo and strain. It's widely available, there's no radiation. The cons, which we mentioned, and for GLS, there's a difference between vendors and the technical requirements of getting a good strain image. MRI is certainly interesting, intriguing. There's been some small studies on it, but it's not really a great, realistic, cost-effective option for patients that are getting chemotherapy. And then biomarkers, they're accurate, they're reproducible, they're widely available. But there's not evidence. Certainly, there's some evidence for troponins, more so than BNP. BNP, if you look at the utility of BNP, this is a review of some of the studies, and they've really been, 6 of one, half dozen of the other in terms of whether they're predictive or not. So looking at troponin, there is evidence for troponin to be a specific biomarker, if not sensitive, and it can predict within 3 months in advance the occurrence of a drop in ejection fraction, and has been used in some studies to trigger the therapy with ACE inhibitors to prevent a decline in ejection fraction. So, and then, this was another recent study that looked at biomarkers, and they looked at a whole panel of biomarkers, and you can see here, and they took these pre-chemotherapy at 3 months and 6 months. One criticism is that a lot of studies are now looking at immediate post-chemotherapy or within 24 hours of post-chemotherapy biomarkers to see if that will more reflect the cardiotoxicity. But this showed some evidence of value for troponin and for myeloperoxidase, which is a biomarker of oxidative stress, but no benefit of BNP or CRP or galactin or any of these other biomarkers. So clearly there's a need for novel biomarkers. This is a position statement from the European Heart Failure Association. This says that the identification and validation of reliable biomarkers for the prediction and detection of cardiotoxicity is urgently required. The use of simple biomarkers such as troponin and BNP should be strongly considered, but it's not a substitute for objective evaluation by echo or similar modalities. So we are on a quest to look at novel biomarkers for anthracycline cardiomyopathy. And originally, I was introduced to an investigator in the Research Institute who's no longer here, who has an interest in nanopeptide biomarkers, and Tony Hugh is his name. And he and Steve Igo connected us because he was already doing research on this with MD Anderson, and we didn't know the other existed. Just the background of how we got involved in this study. So I'm going to very, very briefly talk about the nanopeptides and then move on to the focus, which is on gene expression biomarkers in this field. So this is a 3D silicon nanotrap. So it's a nanomaterial that has a porous structure and allows smaller peptides to fuse into a nanopore and can detect nanoparticles as biomarkers. This has been validated with different studies. And then looking at specific nanopeptides, one nanopeptide that Tony had identified was hepcidin, which is a major regulator of iron metabolism. It inhibits ferroprotein, which ferroprotein helps export iron from the cell. So by inhibiting that, it increases intracellular iron. And we do know that that's a biologically plausible hypothesis, since we know that cardiotoxicity has been attributed to iron-based free radical oxidative stress, and we know that anthracycline has a strong affinity with iron, and that there's an iron chelator, dextroxane, that's used to prevent anthracycline cardiotoxicity in patients that have had high doses in metastatic breast cancer, for example, with more than 300 milligrams per meter squared of anthracycline. It's approved to prevent cardiotoxicity, and it's also used more in the pediatric world as well. So it's biologically plausible, and he had some samples from MD Anderson looking at just troponin levels in patients that had adriamycin, and there was some evidence that those that had a higher troponin also had a higher hepcidin level, and because of that, we were able to kind of piggyback on his. He had a Costas grant to look at that, and so we were able to piggyback on each other and use that to do a prospective study while also getting some biomarkers that I was interested in as well. So the biomarker the biomarker type that I was interested in is looking at genetic expression. So just kind of a quick primer, refresher on genomics. So we know that DNA is the study of DNA, genetics or genomics, and the study of DNA, the study of RNA and its expression is transcriptomics, and once that's translated into protein, proteomics, et cetera. So when you look at transcription, it's really quantifying the RNA levels for both coding and non-coding genes in the genome. And that informs much of the variation in protein levels. So while genome sequencing, for example, is static, gene expression is dynamic, and it depends not only on the genome, but also on the effects of the environment, the disease, drugs, et cetera. So that's what we wanted to approach with this. And gene expression profiling has a lot of use in oncology. For example, there's a signature that can predict survival in patients with breast cancer. The use of gene expression profiling can predict survival after chemo with patients with diffuse large B-cell lymphoma. And you can see different scores in the top right corner show that was very clearly useful in detecting the probability of survival. And also in cardiology, there has been emerging use of transcriptomics. This is a paper from my alma mater showing that you can use a gene expression profile from one biopsy sample in patients with or without myocarditis. And it can, using a gene expression analysis, you can accurately distinguish myocarditis from other types of cardiomyopathy. This is one we're more familiar with in the transplant world, looking at gene expression profiling to use as a substitute for cardiac biopsies. And so this is from peripheral blood monocyte gene expression, and there's a AlloMap score that's based on the gene expression profile, and that has a very good negative predictive value to rule out cellular rejection of a heart transplantation. And then there's also studies that looked at peripheral blood gene expression and the extent of coronary stenosis. So this shows one we submitted this for a grant, and one of the critiques when it came back was that, does the peripheral blood really represent the cardiac blood, the tissue? And looking at least these latter two studies, you can see that there certainly is evidence that it does in these patient populations. And so what's the technique? Just briefly, looking at a microarray gene expression, you isolate the RNA. If you take two different patient samples here, then you have cDNA, and you put reverse transcriptase, and then so you can convert it and label it and put fluorescent tags on it, and then you hybridize it to an array. And for example, if the sample A, if it's red, will have higher genetic expression of those genes. Sample B will have higher genetic expression of those genes. And if it's equivalent, it will be white in this sample, or negative. And then RNA sequencing is what we are planning on using in our study. So RNA sequencing it allows the evaluation of a complete set of an organism's transcribed genes and the non-coding RNAs, such as microRNAs, which are also used frequently nowadays as biomarker discovery. So this also allows to look at SNPs and other transcripts and alternative splice variants. And in a lot of ways, this is preferable over microarray analysis because it's more sensitive, has more dynamic range, and has a higher capacity for discovery of transcripts. So it's being used for biomarker discovery and identifying unique signatures. So our study, our aims of our study are one, so let me show you the timeline first. So we're taking patients that are getting any kind of anthracycline-based chemotherapy. We're baseline getting echo with strain, BNP, troponin. We're getting nanopeptide biomarkers at baseline. We're getting PAX gene is a technology, they're blood tubes that you draw the blood and you're able to stabilize the RNA in the blood without directly freezing it or spinning down the leukocytes. And so it stabilizes the RNA so you can analyze the RNA. So we're getting all that at baseline, and before and after cycle 2, we're getting conventional biomarkers and the nanopeptide biomarkers. And then before and after cycle 4, this is built for typical breast cancer patient getting 4 cycles of anthracycline with cyclophosphamide. And we're getting, after cycle 4, before cycle 4, the PAX gene tubes as well. And then we're doing it serially at 6 months and 1 year to see how those changes have maintained or not throughout the year. And we're getting echoes, of course, at 6 months and 1 year as well. Now, for some patients are enrolled that have AML or lymphomas or leukemias, and they're getting all their upfront chemo in those first couple weeks. And in that population, we're getting baseline studies at 6 months and studies at 1 year. So our specific aims, one is you want to look at the patterns of gene expression and see if just the baseline patterns predict cardiotoxicity. And that's really not, that should be specific aim 2, frankly, because the main aim we want to do and what we think is the most, has the most hope to show us something would be to see if there's any serial change in the gene expression signatures for patients that are getting chemotherapy to see if that can predict the onset of cardiotoxicity. So we'll be using the RNA sequencing and bioinformatics to do so. And then basically pretty much easy inclusion criteria. Anyone that's adult that's starting anthracycline-based chemotherapy, unless they've had a prior or current history of a depressed EF. And we're defining cardiotoxicity pretty standard as a 5% reduction in EF and below 55 and symptomatic heart failure, or asymptomatic patients with a greater than or equal to 10% reduction in EF with the EF decline less than 55%. We're also going to be including a little bit broader definition for a change in GLS greater than 12% from baseline or greater than -18, or an elevation of troponin 2 times greater than the lab limit, or new arrhythmias requiring treatment. And so going back to whether the peripheral blood we're getting really correlates with tissue, the reason why we want to get blood rather than biopsying all these patients is blood's obviously cheaper, more convenient. Patients don't like having procedures. It's more practical in a real-life setting. Blood is in contact with all the tissues in the body, obviously, and thus it may reflect changes in that organ. This is a study now 10 years old that looked at the peripheral blood transcriptome from 9 different, and it correlates, if it correlated with 9 different human tissues. And it showed there was great correlation between the tissue blood and the gene expression from the blood among all these tissues. And looking at the heart, there was 84% of genes were co-expressed. So there certainly is rationale for using peripheral blood in this population. Looking at, when we started this study, this is the only thing that was out there, and this was a rat model that looked at transcriptome profiling of peripheral cells, and they correlated it with cardiac tissue from the rats, and showed there was a correlation between the peripheral blood and the gene expression in the heart in these patients, and the pathways they found, for what it's worth, that were differentially expressed in these patients had to do with oxidative stress and protein ubiquitination. Unfortunately, I have to say, since I was preparing these slides, I've did a new lit search that for the first time in 9 months, and now there's 2 articles that look at microRNA expression in human samples that are getting anthracycline. So if you have a good idea, do it early and do it quick. So, and someone will still probably beat you to it. So the critique that we had is that from the reviewers was that how can we assume that the peripheral blood will reflect the cardiac gene expression? So I think looking at some of the data we've shown and looking at how it's worked in other studies, I think it is. There is good data to show that the peripheral blood gene expression does reflect to a large degree or to a certain degree the other tissues, including the heart. Nevertheless, it is fair to say that we should prove that in this cohort. So we will enroll a small sub-study of patients, probably 5 controls and 5 patients with suspected anthracycline cardiomyopathy, to have biopsies and look at and see, just to prove that their blood and their biopsies have similar expression of genes in these patients. So we're going to be collaborating with J.B. Durand and M.D. Anderson, who's a cardiologist, and he has an active biopsy protocol of patients with anthracycline cardiomyopathy. So he also has privileges here. So he will be coming here to enroll these patients and helping us get their samples. Another critique that we had was that we needed to have a control to explain to allow for the confounding effect of the chemotherapy on the gene expression profiles. And how do we know that the chemotherapy is not going to affect their gene expression in a certain way? So, the original plan was to not have another control. The patients will have a baseline gene expression profile before chemo, and then there'll be 2 groups, one that has no cardiotoxicity, one that does have cardiotoxicity. So, we really wanted to see what the difference is in gene expression between those 2 groups and how it explains cardiotoxicity. So, really, to please the reviewers, we're thinking about having a control with a group that's getting non-anthracycline chemotherapy for breast cancer. Although this does add another layer of complexity to the data, which is already complex to begin with, given the bioinformatics and the genomics. So just a little bit more about the concept of biomarker studies with gene expression. One is there's two ways you can approach biomarker studies. One is having a targeted approach, which means you have a candidate gene expression, you have a candidate pathway that you want to look at, and you can look at specific those pathways a priori. That obviously has a lower burden of statistical testing. It's less complex from the bioinformatics. It is disadvantageous in that it does limit you to that one specific pathway. Whereas untargeted or discovery markers, it's kind of the hallmark of omics studies. It's hypothesis generating, it's unbiased, although it does have the disadvantage of having the need for more complicated bioinformatics, but that's why we have people like Leif Peterson here who's going to help us make that less complicated. So looking at our study, this is we've been doing this for 2 years now, and we've enrolled 94 patients so far, and I want to thank Rachel here for really doing all this tremendous amount of work to enroll all these patients in this study, and it's really she's been here nights and weekends to enroll patients whenever needed, and it's really a remarkable effort. So out of these 94 patients, the majority are breast cancer patients. We've had 28 that are hematological malignancies and 8 that have other cancers. So looking more in the details, we have of the 58 patients that have breast cancer, 15 have so far completed 1 year of the study. So they've completed the study and have all their data. Out of those, 2 of those had clinical heart failure with a drop in EF. And 11 have completed 6 months of the study so far, and 4 of those have had a change in their strain, but have not yet, hopefully, developed cardiotoxicity otherwise. And of the 28 patients with hematological malignancies, we've had 7 complete 1-year study, and 2 of those have had a drop in their EF, including 1 who unfortunately died with multi-organ failure. And 3 have completed 6 months, and 1 has only completed 3 months but has had clinical heart failure with a drop in EF. Of the 8 patients with other types of cancer, there's 1 that's completed the 1 year, and 3 that have, and 1's completed the 3 months so far, and already had a drop in EF and heart failures. So in summary, there's been 8 patients with heart failure. 23 that have completed a 1-year follow-up, 2 that have passed away only, unfortunately, and we don't have their follow-up biomarker data because they died before they can get it, and 2 that have so far completed 3 months of data. Looking at their baseline characteristics, the average age is 56, mainly female. Race is mainly Caucasian, 28% Hispanic, 10% African American. So the comorbidities, about 1/3 of them had hypertension and hyperlipidemia, and 15% tobacco, and 5% with a family history of heart failure. Looking at their baseline clinical characteristics, predominantly breast cancer. The rest, there was 2 non-Hodgkin lymphomas, 11 with AML, 5 with diffuse large B-cell lymphoma, 5 with ALL, and of the others was predominantly ovarian. 5 out of 8 were ovarian cancer. The mean number of cycles is 3.6 with adriamycin. Mean EF at baseline was 63. GLS, we wanted to be less than -18, so a higher absolute value of 18 at baseline, so the average was -18.5. And baseline BNP and troponin, as you see here. And looking at their chemotherapy regimens, the majority, or 44%, received for breast cancer adriamycin and cyclophosphamide plus Taxol. The rest had some slight variation of that. And then there were 4 with EPOC, and 6 with hyper-CVAD, and 10 with 7 + 3, which is 7 days of cytarabine and 3 days of anthracyclines, all up front. For leukemia. And the cumulative doses for doxorubicin, the cumulative mean dose was 233, which is lower than you saw from that Italian study, which was close to 300. But nevertheless, we still do have a pretty decent incidence of cardiotoxicity in our patient population. Looking at the what's happened to these patients, the 22 on the left, those patients all had no change in their EF or strain pattern. These 3 plus 4, I don't know if you can see the arrow, but the 3 green and the 3 light blue there, those all had a drop in EF with symptoms. So 7 patients had a drop in EF, and half of those had a GLS that predicted that. And then 13 patients dropped their GLS and to a significant value, and we're still following those patients to see if they manifest more conventional diagnosis of cardiotoxicity. The mean EF across all patients and mean GLS across all patients you can see here. And then in the cardiotoxicity patients, so the 7 patients who dropped their EF versus the 22 controls that have completed the study, the real difference is age was higher in the cardiotoxicity, not unexpected. And we know that higher the age, the higher the risk of cardiotoxicity and heart failure in general. The mean BNP and the mean troponin was higher in those populations. But I will say that there was only, I think, 2 patients that had an elevation in their troponin out of all those 7. And the BNP, while it was impressive for 2 or 3 of those patients, was generally, when the BNP was elevated, the EF was already dropped. And then there was no difference in the concomitant radiation therapy or anthracycline dose in those patients. And looking at the cardiotoxic patients versus the controls, you see the difference in ejection fraction here, which tended to drop early at 1 and 3 months and rebound a little bit, versus the GLS also dropped early as well. And then looking specifically at the patients that we have here, so we have the first 2 patients were both patients with breast cancer. These are all patients the 7 patients that dropped their EF. You can see both the 2 breast cancer patients had an abnormal GLS at baseline. So their strain was 16.9, 14.9 at baseline, normal biomarkers, the conventional biomarkers. And then by 3 months, the first one dropped their EF to 42%, and by 6 months, the second patient dropped their EF to 44%. The third patient with AML died after their first chemo, and so we'll only have their baseline studies. The fourth patient with lymphoma dropped their EF pretty early at 3 months and has completed 1 year. So right now, those are 3 pure samples we can look at for cardiotoxicity. The ovarian cancer patient unfortunately died early, and we don't have her samples. The pancreatic cancer is at 6 months so far, or 4 months so far, and her EF is just dropped, and we're awaiting further samples. And the last patient with AML has a drop in their EF at 3 months and is still being enrolled. So right now, that's 3 patients with clear cardiotoxicity that have completed 1 year, and we'd like to get at least 5 before we start doing initial analysis. So then just briefly, the 2 other projects we're doing under the cardio-oncology fold, we're doing one gene study looking at kind of the reverse. We're taking patients that have known anthracycline cardiomyopathy, doing a whole genome sequencing and a careful family history to see if there's any genetic predisposition to anthracycline cardiomyopathy. So that's undergoing, and we have another study where we just clinically have noticed a lot of these patients have a high resting heart rate, and some of the times that I've seen that before, their EF drops, and there's no data existing on that. And so what we're doing is we're giving Fitbits to patients with breast cancer that are undergoing anthracycline-based chemotherapy versus another group that's getting Taxol and non-anthracycline cardiomyopathy, non-anthracycline chemotherapy, to see if there's an increase in resting heart rate that will predict the onset of cardiotoxicity. So that's really, that's it. And hopefully by now the Astros have regained the lead, but I doubt it. And just want to thank the collaborators on this project. Leif Peterson, who's here, who's an expert in bioinformatics, among other things, and Polly Nirvath from oncology, Kai-Fu Chen from the RI, and Rachel Arujo, who is really done the grunt of the work in terms of data collection and analysis and everything else. So. Any questions?
This is great work. There's a lot of data points to collect and to do. The question I have is, what's the target N? Because to me, it seems like this is the hardest thing in the study, is getting the N and the N with the heart failure,
Yeah.
to be able to do the comparison.
So the N of what I want to analyze is different than the N of what we have to enroll to get there. So I mean, if you know, average, if we say 10% of patients that get chemotherapy are cardiotoxic with a drop in EF, and that's just, the data is all over the place from 3% to 20%, but we're, from what we interpret the data, we're going around that 9 to 10% range. So if we want to, in the end, analyze 10 patients that have pure cardiotoxicity, so one extreme, and compare them to another control that's another pure extreme that didn't have any biomarker elevation or strain change or any slight evidence of cardiotoxicity, so kind of compare one pure group to one pure group, then you'd have to enroll at least 100 patients to get 10 patients that have cardiotoxicity. So right now we've so far we're almost there in terms of that. Then of course that's for a discovery cohort, and then we'll need a validation cohort after that. So we'll hope to enroll a smaller validation cohort, maybe of 50 patients. So, but
the reason I'm asking this is because from the standard deviation I'm seeing, it's not going to be like the EF is going to be widely changed, right? So you're going to have like the 10%, the 2%, the whatever percent. So if you have a bigger cohort, it'll be easy to stratify them in groups. But if you have 5 to 10 patients, it's going to be one in each group or a couple in each group.
Well, I think we're trying to find the one pure group of extremes. So we're not going to have put someone with a 48% EF necessarily in this, who doesn't have clinical heart failure that on one echo that goes back up to 55. We're trying to find groups that really have clinical heart failure with a drop in EF. And I don't know, Leif, if you have any comments on the sample size and for these kind of studies that involved complex genomics.
There's so much genomic exploratory work that needs to be done that we kind of really, there's some random mouse data from which we get power for the gene expression, because there are clearly lots of handfuls of genes with fold change greater than 2, but with humans, you never really get those high fold changes like 30 and 40 with mice. But I think for the exploratory, it would be too difficult to power from that, for which you could have the sample sizes of 10, 20 or so, just the gene expression data, which is, I already analyzed a data set for mouse myocardiocytes, which they use the typical dose. That's pretty good, but what happens when you, it's like Christy Valentine says, you do mouse experiments, use high-fat chow, low-fat chow, look at gene expression in monocytes, get your power from mice, and then go to NIH, and they know that you need 300 humans before you're going to do anything. So you're just not going to get funded, and no one's going to get funding because of the intense genetic heterogeneity. But something I was thinking about, these are pretty prime cases, the patients with failure that you have right now who are alive. And I'm wondering if the collaborator from Anderson who has rights here in the cath lab, will he only biopsy his patients, or can he not do the?
No, he would only be biopsied his patients. So there's the clinical justification to biopsy these patients is really, if you're not sure whether if they have a drop in EF and you're not sure if it's anthracyclines and they want to give more anthracyclines, that would be the clinical indication to biopsy them. There's not a lot of patients like that, unfortunately, but they have a protocol there at MD Anderson where they're doing it clinically, but they're also taking samples for research, and they do it clinically more often. But it's not kind of an established clinical paradigm we're doing here.
Yeah, one more thing. A thought that came to mind when you were talking about the Anderson patients, this small handful that will be catheterized here to get a biopsy. Typically in oncology or in many specialties, when you want to, it's really a big player in oncology. Everyone is seeking out nanochips, nanobiochips, identify serum plasma markers that you can pull out of blood, or serum plasma, right? But in oncology, the distribution and the expression of those proteins in serum plasma, they must correlate with protein expression in the tumors, because the disease is in the tumor. Just like I had said, the disease is in the myocardiocytes. So with the patients that you can biopsy, it would be really good to possibly enrich in the two extremes. Find they're going to be diseased probably, right? So pull the biopsies, and then also get their peripheral blood lymphocytes and run gene expression in those, because if you can find correlation in gene expression from the peripheral lymphocytes of those patients, then you need to run RNA-seq on the myocardial site tissue as well.
Yeah, that's actually the plan. That's the plan, to do it simultaneous, and then we can compare. And then with the PAX-gene tubes, we don't have to spin down the cells. It will allow for RNA expression analysis without having to spin it down. The technology in the tube will really help with that without having to spin down the leukocytes. So, Keith.
One comment I'd like to make: a lot of the studies you showed in the early part that other people have done, they use the Illumina microarrays. You're really limited there to like 5,000 genes, and they have to be genes that are expressed both in the heart and in the leukocytes in this particular case. And so you end up with a really small subset of things that you can see change. You're going to get a better bang if you do the RNA-seq, because the RNA-seq also includes the SNPs, the microRNAs, and now all of a sudden you've got 200,000 markers you can look at.
Yeah.
And that's how they did the AlloMap in a sense. They did a large number of markers. They didn't care about what exactly pathway each one was associated with, which ones were associated with, in that case, rejection. And then regardless of what they represented, if they were up, they became a marker.
Yeah, that's the plan. That's our plan.
They had a very small number of patients that they used, that had positive rejection, that they mapped that to.
That's exactly the plan. So, originally I was going to do microarray, with Illumina, and then work with our collaborators. We've been convinced of exactly what you said. Yeah.
They've come down in price a lot, so that's really the way to go now. And with the bioinformatics people, if you can screen a large data set and pull out a fingerprint, so to speak, it wouldn't have to be the pathways, but a fingerprint for responders and non-responders.
Yes, the cost-wise here, the go-to is Weill Cornell, but I've heard so many horror stories on cases where they've infected libraries with bacteria and people running RNA-seq. And a lot of lab directors will say, I'm doing RNA-seq. Well, it takes you need really, really golden hands, and you really, really need to know a lot about what you're doing to do RNA-seq. Not everyone can do it. So it's like golden hands squared to be able to pull it off, really with the techniques. But so we've been going over to Baylor, because with their QC, you can't.
Baylor's got a good facility.
You can have no problems, but it works out. I can get a faculty discount there for about $1,100 or $1K per person. So it's still like if you're running the athlete.
Well, we just found one that was $250 per sample, and we're testing Bimraj's samples, so we'll see if they're any better.
It's good to test them on yours first.
But I think to that point, we decided actually not to even isolate RNA here. We just ship the whole sample so that the lab that does.
Yeah.
Let the experts do it.
Absolutely. Yeah, we store it in the right process, the right way, and then we're happy to yeah.
And they can run nanostring chip for circulating microRNAs for $45.
Yeah, because those will give you a lot of insight into, it might tell you who has a predisposition to develop it. So even some of their samples before therapies may actually give you some hits, as well as those that responded after they were given.
Yeah,
so
that's true.
When you looked at the GLS change, I think the over drop is the best clinical outcome. The N is smaller, but if you look at your GLS strain, change, it starts dropping early, 1 month.
Yeah.
So if you want to use, there
So for the breast cancer patients, we have it baseline and after cycle 4, which is generally around 3 months, and then for the hematological ones, so we actually, and no one pointed it out, but we're getting them at baseline at 6 months. So we really, in looking at things, I think in retrospect, I'd like to have a sample closer to after the first chemotherapy. We were trying to save money initially with all the tubes, and I think I'd like to shift those up front after their first round. I mean, their only round of chemotherapy typically, to get those samples in the hematological patients.
Because if you drop by 1 month, you probably want to analyze your baseline data to show the predictability, right? On people who drop versus not.
Yeah.
Because if you look at 6-month sample of people who already dropped before, then it's tough to know which happened first. It's happened
Yeah.
quite early, right?
Yeah, I mean, I think your point being, that the change, early GLS change is clinically meaningful, and that would be a good target for a biomarker. I think that's what your point is, and I think that's a very valid point, and I think that's kind of second phase. But I think to really see if there's a clear difference in molecular expression, I want a more extreme cohort to really see if something else, yeah.
But your intent is to look at people who drop their EF, but look at or the gene expression at that time?
So, no, I mean, before, to see if there's something before that can predict the onset of EF change.
I mean,
So,
almost it comes down to, even at baseline, can you look at people who drop their EF versus not, like just do a baseline assessment?
well, we're doing that too, but I think to me, and we're going to do that for sure. That's one of the main, one of the two aims. But I think for me, what's more interesting is if there's something that can predict those that are getting chemo. If they've gotten a few cycles and you see a change in the signature, whether you should, prophylact them with.
But that will give you your mechanistic pathways.
Right.
No, I think you're right. If you just find the change at that time, but the prediction, like at baseline, you can come up if you find a map, a signature saying at baseline you do a gene expression profiling, and then you say that these guys will develop cardiomyopathy or drop in whatever outcome. Those are the guys who should go on ACE inhibitors, who should go on beta blockers, and then you protect them versus but at the time of their drop, the question becomes you'll find association, but you might not find, like you give you mechanistic insight.
Right. No, we want to do it. So that's why we're getting so many samples, because we're trying to get it to predict. And frankly, that Italian paper that showed that was kind of, for me at least, landmark, that showed 98% of patients that have cardiotoxicity are dropping it within their first year. That was really game changing for me. But the study was already ongoing when that data came out. So if I hadn't seen that data before, I probably would have put more of the analysis up front earlier. No, we do. We have baseline, and then we have after basically 3 months and 6 months and a year, basically.
Baseline, you can analyze people who drop the GLS or not, and you find a signal, you're done. I mean, you already have a biomarker test that you.
But that, if you're talking baseline, that's before they're giving chemotherapy. That would be people who have a predisposition. If you wait till after the first therapy, then you're looking at how they responded to that.
But at baseline, if you already find a difference,
right,
that is a golden test.
Yeah, that might be nice if you can find that, but I think you're more apt to see
don't,
something after the first therapy.
You could sort it out. You'd be able to pull out a signal for developing heart failure, and then chemotherapy sensitivity, and then go back and see. You could subtract out and try to identify gene expression profiles that are predictive of heart failure in receiving docs exposure. One of the things I told Barry when he said he was going to get gene expression in peripheral blood lymphocytes, I personally, because I commonly work in oncology, that you always need to get gene expression in the tissue. I had always thought even though you have 84% shared gene expression between PBLs and myocardiocytes, which was shown in the paper, the gene regulatory control system and the disease process of myocardiocytes, which are muscle cells, has nothing to do with the genetic coding in the peripheral blood lymphocyte. So therefore, I thought you need to salvage the entire design, go back early, and then run SNPs,
Right.
and then follow everybody up, and then use SNPs to look for susceptibility SNPs between the two extremes of groups. That's a valid question, and it's out there. It's just other information.
Right. And that's the beauty of the RNA sequence, that you can get
Yeah, and that's
all
why
that
I say the
information.
RNA seq, because that's going to
Yeah.
give you the SNPs, the microRNAs, all the things that aren't necessarily associated with the lymphocyte.
But I think that as Keith's pointing, the proof of concept lies in the AlloMap test, which is commercially available. That's all they did. It's a power of informatics on finding association.
And they have no mechanism in there
Some
at
of
all.
the genes that make no sense, but they were able to perform it, validate it, and then show that it's a biomarker. But I think for mechanisms, if you want to devise therapeutic interventions and then explore mechanisms, then you probably need myocardial tissue at some point to validate.
So we have a small cohort of around 5 patients, but these are end-stage heart failure patients that got an alveolar transplant. I think I mentioned it before. I mean, we could validate.
Yeah, no, that was the backup plan. I think that's a good backup plan because we have them from heart explant. I think it's too advanced. I think to
No, we don't
really.
want to look at the late samples.
Right.
Because
Yeah.
the late
Yeah.
samples, we're looking at response to heart failure, not response to chemotherapy.
Right. And that would maybe at least show the correlation, but I think we could do that with any type of patient, that's biopsy or explant, to show correlation. So I think now that we have a prospective option, we'll be able to do that.
Are
So
oncology guys here against myocardial biopsy?
they're not enthusiastic about it.
A quick one, Barry. So in genomics, we're always worried about costs and how much things cost. But certainly, for you, we can't get any clinical information without your stress imaging and those consulting costs. So you're certainly not going to say, I'm going to do all this imaging and all this analysis clinically and go to your chair and go, I'm doing all this work and there's no revenue. So how do you cost that? Do you say each stress image is $1,000 for consulting? Or
so those echoes are all should be standard of care. It's standard of care. The truth is, because of the research patients are followed more closely, we're able to ensure they get those standard of care echoes more frequently than the patients that aren't in the research study. But patients that we're seeing that are not doing research, they're getting this too, and they should be really getting at least the echoes. And there's good evidence to support the biomarkers of troponin more than BNP as standard of care.
So you don't have to devote clinical consultation to get that's done.
No.
You don't have anything to do with it.
I might, but it's not necessary.
Okay.
It's not.
So you don't have to cost it.
No.
Yeah.
No. So.
Do you have a single person to perform and interpret and read the echoes and the strain?
No.
Just for reproducibility and reliability?
No.
You don't?
No. But if we ever want to submit this, if we have good data and we want to submit this to a really high impact journal, then we can go back and have one person review the quality.
But the GLS is an automatic software.
It is, but some.
Tracing is accurate.
Yeah. So as long as it's yeah.
I different same piece like if very subjective when you
Are the techs marking it or are the physicians?
The techs are marking it. So I mean, I don't know how often our echocardiograpers are going back and changing it, but I.
Change it actually when it's on DG. And a lot of the times it's not tracking well.
Now, if it's not tracking well, will you delete it from the report, or you'll keep it in the report?
I personally don't report
Yeah.
when I see that's not tracking a certain segment.
Yeah.
I mean, it depends on the original quality of the image.
Yeah. And there's a way to do it. I mean, after the images are taken.
It
Yeah.
can be based on a specific software later.
Yeah.
You can do a validation of part of a cohort and get one person
Yeah.
and then just see if it is, if you have inter-observer variability, if it's not.
Did you consider age and gender matched non-ischemic heart failure controls to compare the RNA-seq pattern to the pattern you're seeing in the toxicity patients?
I thought that's a very good point. Actually, that that would be a good workaround to the other control, which is the other chemo group. There was criticism about the effect of the chemotherapy. So I'm grappling with enrolling patients that are getting non-anthracycline cardiomyopathy, non-anthracycline chemotherapy, and tracking their gene expression. But that's actually I think that might be an interesting alternative, is just to get patients with heart failure without chemotherapy to compare to. I think that would be attractive. That's a good suggestion. Thanks, Phil.
It's a very nice cohort, and you have a nice collection of patients getting not only anthracycline but other chemotherapy agents, and quite a few of those have been indicated for cardiotoxicity. Are you going to look at those as a separate group as well?
So really, I mean, so there's surprisingly only a couple patients were getting a HER2 antagonist. So there are, you can have toxicity with, for example, cyclophosphamide, but it's pretty rare. So I think for most of these, with the exception of the HER2 antagonist, there's not too much that we need to account for. And the bulk of these will be the AC Taxol group anyways. But that's a good point.
Barry, explain to me, why do you need like you talked about that as criticism, why do you need a control when you have your internal control of people who had an outcome versus not?
That's what, yeah.
For Delta, right?
Yeah. So
Non-anthracycline.
yeah. Well, I think that the point the reviewers made, and that doesn't mean that they're right, is that the confounding effect of the chemotherapy on the gene expression is not accounted for because there's no control. But I agree with you that if you have a baseline gene expression profile before chemo, and then you have two cohorts, one that gets cardiotoxicity and one that doesn't, with the same chemo, and you want to look for a cohort a signature that correlates with the cardiotoxicity, and one that doesn't. So.
Chemo is neutral in both the groups. So that's
Right. So I agree, and I'm grappling with whether I want to placate them and put one in, versus standing my ground and saying it's an unnecessary addition.
It's just a primary reviewer, he had a concern that the anthracyclines are doing something to the peripheral blood,
Right.
gene expression in peripheral blood leukocytes. So.
But that would wash out
control for
from
that.
the two groups.
Yeah,
Yeah.
with the current design, you'd be able to figure it all out.
Yeah.
Susceptibility or predictability.
Yeah.
But he just thought, well, what do you know? It's just a vanilla flavored confounding term. Your gene expression is going to be confounded by anthracyclines.
Yeah.
But at baseline, we have our donor hearts to fuck. We have 5 patients with full gene expression, which are donor normal hearts. So at baseline, if you want, you can use that as a.
Actually, that's exactly what I was going to propose. Is when we have donor hearts that
We'll have full gene expression
without
of that.
chemotherapy.
But these are patients without heart failure. So Dr. Hamilton's point about having a matched cohort with heart failure but not with chemo, that's an interesting idea, I think, in terms of, both with heart failure but taking away the chemotherapy effect in one group, but otherwise matching them. That would be interesting to me. But I agree that I don't think there's as much of a need for a control. It's already a built-in control, but I'm grappling whether to add that to placate them or not.
So moving forward, looking at the future, if this is successful, then you get an R01, you get DoD and secret, right? Putting this together as heart failure patients.
I hope someone's listening.
And as cardiovascular patients are going to continually come into this huge center of excellence, right, with society presidents, 30 society presidents who come out of the woodwork in cardiovascular care. If you ask heart failure patients, even many that have given like ischemic types, have you ever had thoracic rehabilitation, or are you a cancer survivor who's had chemo? What would you get? What percentage would that be, do you think?
If I ask,
What's the prevalence
so the prevalence in terms of
being a cancer survivor with heart failure?
So, if you look at all comers, it's a difficult question. But if you look at anthracycline, then the incidence is in that broad range of 5 to 20%, 5 to 26%, but probably around 9 to 10%. But the childhood survivors, we have a lot more data. I mean, the childhood survivors of cancer, they're like 10 to 15 times more likely to die earlier and to have heart failure. So it's a much larger incidence, and I don't know the exact incidence, but a much larger data that we have for childhood because there's databases. Yeah, so among our evals, it was 4% of patients that had, 4% of patients with end-stage heart failure had chemotherapy at adriamycin.
8% of non-ischemic.
Yeah.
So like for kids, do oncologists now train patients that, they're, I suppose, following up annually, maybe, if you go in a mission, you're clear. Do they tell them, come back to our cancer center if you develop cardiovascular problems, or? So Methodist would probably pick up cancer, kids survivors more.
Yeah, the truth is, I think there's increasing awareness of this field of cardio-oncology, but that said, I think the majority of oncologists, especially outside of academic centers, are probably not screening with echoes frequently or warning their patients that they might develop heart failure down the road. I think a lot of them express that these patients are so overwhelmed with the diagnosis of cancer, they don't tell them much about the possibility of having heart failure and dying from heart failure later. So that said, at least here, Dr. Niravath is working on cancer survivorship programs, and us working with cardio-oncology, screening and follow-up. So hopefully there's more awareness, but right now it's
Virus leadership in creating this program is probably the biggest barrier to break. As he was pointing out, historically, in the majority of the world, oncologists don't want to do an echo. They don't want to see any changes in the heart because they want to keep giving chemotherapy. And it's interesting when you look at the definition of cardiotoxicity and go back and look at NCI, National Cancer Institute definition, it starts from being very vague in the past. They don't want EF, they don't want anything, and then slowly it got simplified. So I think we've come a long way in this regard. There's a lot of kind of community education among oncologists, and I think the barriers are broken. Now they realize the reason why we're doing this is we want to make sure you can give more chemo so that we start early, pick up the biomarkers, treat them. I think that kind of the trust and interest. In the past, that's what used to happen. The cardiology guys would say EF is low. And then everybody freaks out, the patient's freaking out, and then it's helped out. But then that's all late on. So I think it's an evolution, which I think, as you said, we're probably kind of leading the front of that.
It's difficult to solve the problem. You have genetic susceptibility to anticoagulants, right? And PharmDs here will approach me and go, hey, the label from the FDA said we should do genetic testing for genotyping before we use this drug, and we're not doing that here. I go, oh, really? So
no, it's a challenge to make it clinically applicable for absolutely. So we'll see if we can get good research done first. All right, thank you guys very much for your attention. I really appreciate it.